Thanks very much. Thank you to Gordon and the Association for the invite. I'm speaking today purely in a personal capacity. So I've been involved for the last, I guess, nearly 3 years with something called Healthier Together, and I'm also obviously employed by my own trust in Salford, but I'm not here representing either of those, and I kind of make that point, I guess, because we're in sort of a period of political purdah. That said, having listened to the talk just before coffee by Prof. Tallis, I think I'm sort of reassured that my talk's going to be less controversial against that than I thought it might be. I agreed with pretty much everything he said, however. So hopefully I won't be thrown away in the tower. Well, as you know, you're sitting in a great city. We're at the centre of the first industrial revolution. We developed the first commercially available computer. We've invented graphene. For all that, though, on pretty much any health metric you may wish to look at, we don't do very well. We do below average. Why is that? Well, the reasons are complex and multiple, but it's not for a shortage of hospitals, that's for sure. If those rumbles in your abdomen turn out not to be just the anticipation of lunch and something slightly more serious, you've got no less than 10 A&E departments to choose from where you could have your surgical needs met. What's more, if you should wander out and take advantage of the sun that Ian's referenced and unfortunately step in front of one of the trams, you could go to any one of 3 trauma units or indeed 3 other trauma centres within the city, all of which specialise in something. So we really are spoilt for choice. Now, my task today is to tell you a little bit of what we've learned, so I guess mainly what I've learned from a period of potential reconfiguration of several hospital services, but in particular general surgery in Greater Manchester. And time won't allow me to go through the minutes of 1,000 meetings in chronological order, but only by way of kind of context, really, an overview. This is kind of where we are and how we got here. The Royal College produced some standards for general surgery in 2011, at about the same time as standards were being produced for a number of other hospital acute services. And early in 2012, the commissioners approached us, the organisations, the foundation trusts and provider organisations in Greater Manchester, and said, is there a problem with general surgery? Send us some surgeons. So representatives went from the organisations and over a period of time agreed there was a problem. About the same time, they reminded us, we also need to take about 20% out of the costs of healthcare, a figure that was subsequently revised up, as you will doubtless be aware. Having agreed that there was a potential case for change, Healthier Together, as it became known, was born. And throughout 2012 and into 2013, we put the meat on the bones of the case for change and a potential future model of care, which led in the summer of 2014 to us producing a pre-consultation business case and going to public consultation for 3 months. And that was a fairly intense period of time, which we'll touch on. And we're now out the other side of that. The nature of these things, they tend to attract a certain amount of hyperbole. It was described as the largest ever public consultation in the NHS of its type. Whether that's true or not, I'm not sure. Maybe the emphasis is on of its type, but certainly we've got 30,000 responses to that consultation. And we're now refreshing the details of the proposed model of care ahead of the commissioners making some announcements around so-called specialists in general hospitals shortly after the election and the period of purdah. So what have we learnt, and I guess in particular what have I learnt? Key to this, if you're going to go down this line, is having a case for change. Sounds obvious, but it's very easy to get a group of clinicians together in a room, start chewing the cud, agreeing things aren't right, starting to propose solutions, and actually losing sight of how it all started and what would you fall back on when people challenge you for the big changes you're proposing to make. So you need to be able to articulate a very clear case for change in 1 or 2 sentences. At an early stage, we were able to identify variations in process. We could see that if you came in with an abscess, you might get it treated within 10 minutes, you might be there for 3 days. If you came in with biliary colic, you might get your operation conducted within 24 hours by an enthusiast, or you may languish in a ward until somebody comes to the end of their on-call week, finding every excuse under the sun not to do the operation, handing it on to somebody else on a Friday who decides this isn't an operation for a weekend, and being in hospital for 8 days before being discharged home and going on an outpatient waiting list. Importantly, we had the standards to fall back on. They'd only recently been produced, and over time we were able to demonstrate that none of the organisations in Greater Manchester were meeting the standards for a number of in-scope services, but in particular for general surgery. So there was clear variation in process. Okay, process matters, but it's not everything. What about outcomes? We were also able to demonstrate significant variation in outcomes too. And the commissioners fell back on commissioning a piece of work from Dr. Foster. When they did so, they were able to describe more than 500 deaths for patients undergoing general surgical procedures in Greater Manchester per year, but up to twofold variation between organisations. When you start to extrapolate from that, you start to see potentially a significant number of lives to be saved. For context, the trauma reconfiguration that had already happened by this stage in Greater Manchester, at least up to the point it had reached at that point, was predicated on saving tens of lives a year. And here we're talking about trying to save several orders of magnitude greater than that. So it's important that you have a case for change that you can articulate, but it's also important that you describe a clear model of care that's going to address the shortcomings and address the case for change. And we spent much of 2013 working our way through that. Now, time won't allow me to go through the fine detail of the proposed model of care for Greater Manchester, and apart from anything else, it's not necessarily directly transferable to anywhere else. It's kind of the lessons, really, that I think are important. What I think is important is that the model should be as simple as possible, at least in its most basic level. And what we found over the course of the year is every time we changed the model, it got simpler. We set off with different types of hospitals, ones that would do cold elective work, ones that would have an A&E and do acute medicine but not emergency surgery, ones that would specialise in trauma but not this and not that. Over time, it just got simpler. And the doctrine was to keep as many patients as possible local to their home, in particular for medicine, because of the obvious interconnections between acute medicine, frail elderly and community care. But that for a relatively small proportion of surgical patients, there were going to be advantages to be obtained from undertaking their care on a smaller number of high-risk sites, if you like, putting all our high-risk patients in a smaller number of baskets. To address some of the shortcomings that we saw in the standards, our inability to provide consultant care for operations at night because we're compromised from having been working during the day and being back in the morning, our inability to get a registrar down to the A&E department to see the sick patient there because the only registrar on call is already in theatre or doing something else, our inability to provide reliable care at weekends, in particular ward rounds for high-risk elective patients, and so on. If we're going to address that, we need to put the patients into a smaller number of sites where we could put a larger number of us around the clock, 24/7. And so the model grew from there. So what have we learned? I'm acutely aware as I describe this that there will be others in the audience who've been through transformations and reconfigurations of services, and I'm not here to teach Granny to suck eggs, but it is fair to say that the proposals for Greater Manchester are amongst the largest. We're talking about taking some high-risk general surgery out of 10 existing hospitals and doing it on only 4 or 5 sites. And given the role that general surgery has to play in all of our hospitals, that is a fairly big deal. You can't do this without a team, and you can't do it without a due process. We require the 12 CCGs that cover Greater Manchester to come together to form an agreement. They speak as one currently, as something called the Committee in Common, and we hope that they'll continue to speak as one, because if they don't, all this won't achieve what we need it to do. But you don't need me to tell you that in a city of 3 million people, there's going to be 3 million strongly held opinions on how healthcare should be delivered. And you also don't need me to go into much detail about the legal obligations. You heard some of that before the coffee break. The rules around these things are labyrinthine, and you simply can't progress through the process unless you involve people who know what they're doing. And that doesn't just mean clinicians, that means very senior and very experienced non-clinicians who are familiar with the rules that have to be followed. Many of the options on the table for where we might do our high-risk work have merit. In fact, they all have some merit. We described fixed points. That's to say, we identified organisations that were going to be high-risk sites and actually weren't up for the public consultation. If you're going to do that, you need to do that on extremely solid legal ground, because it's going to get challenged. And your decision-making criteria need to be extremely robust. One thing that we found very helpful was very early public engagement. So although the public consultation wasn't until 2014, we started the town hall chats in 2012. Before it was too important in some ways, before it carried actual weight. And why do we do that? It allowed us to test the case. Could we articulate it very clearly? If not, was it because the case wasn't strong enough, or was it because we just weren't articulating it very well? So we got better at that. It also allowed us to articulate the model. Again, it became iterative, and we started to understand which bits were easy to understand and which bits made less sense. Actually, the public are your ally. If you're doing this properly and you're explaining it properly, the public are on your side. So there were many meetings in town halls in 2012 where we arrived, usually in the evening, usually after a full day at the coalface, often to banners outside and a fair degree of hostility. And you stand there and you explain what your working day has involved, and you explain that you're now on call for the night with a locum you've not met, and that you may or may not be called. And if you are called, that you're due back in the morning to operate on somebody else's mum or dad. And slowly a hush falls over the hall and people start to engage with the issues. It also allows you to road test the clinicians as well. So at the start of Healthy Together, there were a number of potential in-scope services, not just general surgery, although general surgery seems to have become the most high profile. Women's and children's, for example, was potentially going to be involved, and we deliver women's and children's care currently in 8 hospitals in Greater Manchester, 8 out of the 10. But the clinicians speaking for women's and children's had an opportunity to describe whether they thought there was a case for reducing the number of obstetric sites, reducing the number of sites for paediatric surgery, and how that might be done. It's interesting because it allows the broader group to see to what extent the clinicians that are going to lead this process are actually wedded to it. Do they say we? Do they say I? Or do they start to describe the process in the third person and detach themselves from it? And there's no doubt you can't live through this successfully unless you actually believe in what you're doing. So when we went to public consultation, it looked like this. We proposed reconfiguration of general surgery, A&E, emergency medicine, and changes in primary and integrated care. Now, although there are fairly significant changes to A&E and emergency medicine, actually they're, on the face of it, considerably less significant than for general surgery. No A&E is closing, for example, and we'll continue to have acute medicine on all sites. But we described up front 3 specialist hospitals that would do high-risk general surgery, both emergency and high-risk elective general surgery. 3 hospitals that currently do some of that work that would actually stop doing it and would concentrate on core general healthcare provision. And that left 4 other hospitals, 4 big hospitals that currently provide this care, from which 1 or 2 would continue to provide the high-risk general surgery, but the others wouldn't. You can't do this without a team. And the team provides lots of things, including mutual respect and trust and support. The time commitment involved in this is not to be underestimated. I've been at it for 3 years now, and it's meetings certainly every week. It's emails and telephone conversations every day. Through the 3 months of public consultation, it's meetings almost every night. It's a significant time commitment while still doing the day job. And you need to be able to trust your colleagues. Inevitably, life gets in the way. The stapler will misfire. You've promised you will be there for the meeting at 7 o'clock to talk to 100 people, but you can't because the day job's got in the way. And you need to know that the person who's there to speak for A&E can cover for you, and vice versa. You also need to know that the slides that somebody puts up behind you are the slides that you anticipated were going to be put up behind you and that no one's going to pull a fast one. So you need to grow trust within the team, and we've done that. The actual process and the public consultation in particular is not a job for well-intentioned amateurs. I've touched on already the legal process, etc., that's involved. It comes down to rules like, have you engaged with the hard to access parts of the population? Are the young engaged with it? We put on pop concerts. I think that photo bottom right is the feeling, I'm told. I went home and told my teenage son we'd organised a pop concert. Would he be going? He said no, they were so 2013. But the point is that you need to be shown to, or you need to be seen to be engaging with those hard to access groups. And that takes some expertise. The politics. So you need to understand them, but not be sucked in. A couple of anecdotes. So one MP, shortly before a debate where she and I were up against each other, said sort of off-screen, I'm an opposition MP, I'm going to object to whatever you say. I said, well, you don't know what I'm going to say yet. She said, it doesn't matter, I'm going to object. And you need to understand that for what it is. By way of political balance, I guess, I should make the point that almost uniquely, I guess, in public life, Healthy Together managed to unite all MPs in opposition to us, MPs of all colours. And it's much easier, I think, for the politicians to oppose any proposed changes to healthcare and then blame it on the other side rather than actually engage with it and embrace it. So you need to accept that for what it is. You need to get rid of some of the ammunition by at least briefing them so they can't say they weren't briefed, but you need to understand that the politicians will speak out against your proposals and simply have your responses ready. We had to go and brief the councils. That was a bit of a hoot. You'll have seen health select committees, etc. in Westminster on the TV. This was the local equivalent of select committees. It couldn't have been described as intellectually challenging, it's probably fair to say. But we were required to go and explain our proposals to them, so we did. And the idea was that we'd explain what we were planning to do, and then they would take a vote on whether they supported it. We did our bit, and then they read out a statement for them to vote on that was obviously pre-prepared. It was interesting. I'm paraphrasing slightly, but they announced that they entirely endorsed Healthy Together, entirely endorsed the clinical recommendation that high-risk care is centralised onto a smaller number of sites based on clinically determined plans and criteria with the following caveats. One, that the high-risk sites are the following, etc., etc. So a clear case of all constituents were equal, but their constituents were more equal than others. As we grew in confidence, however, it became clear that it wasn't just the outside looking in to see what we were doing and to try and stop us, but actually they were looking at what we're doing and learning from it. And the 5-year plan announced a few months ago drew, we would like to think, quite heavily on the Healthy Together proposals. Devo Mank, that's coming down the road, we had an inkling that was coming and is somewhat aligned to the proposals for Healthy Together. The power of language and communication. There's certainly things there we got wrong. When we were trying to describe different types of hospitals, the hospitals that would concentrate on providing general surgical services for low and intermediate risk elective surgery versus those that might also provide the more high risk and specialist care, or more high risk elective and emergency care, we were advised that we need to be able to make this easy for the public to understand. Maybe colours were the way to go, red and green, and then suddenly everyone went red, green, colour blind. It suddenly became a competition. We dropped that. We were told, go specialist and general. If anything, that was even worse, but we're stuck with that. It's in the consultation document. Some committee determined that was the way we're going. It's not helped, in truth. It's been more divisive than cohesive. So the language needs to be about no hospital trusts meeting the standards. It has to be about groups of clinicians working across sites, because that's what the model's all about. It's about me doing my high-risk work in one hospital, but being prepared to go out to a neighbouring one to do my low-risk work. It needs to emphasise the single service and the us, not us versus you. You do need to involve a professional communications team. Paul Horrocks led ours. He was the anchor on the TV news up here in the Northwest. He's been the editor of the Manchester Evening News. If you've not had comms training, you need to get it. Having somebody that knows his way around Media City helps. If you do make a bad gaffe live, at least you've got somebody on the inside that can make a few phone calls and go in for a little bit of damage limitation. And different team members have different skills, and you need to use those. And you need to be sort of slightly self-aware of what you're good at, what you're not so good at. I'm not bad at talking to 5 pensioners over a cup of tea and a biscuit. I was all right on the radio. I wasn't so good on TV. We have a GP who's actually very good on GP. He's less threatening than a nasty surgeon. And you need to have insight into that and use the talents of the team. And big hitters, they have a role. If you've got a big announcement to make, bring in big hitters from outside. Dame Ruth Carnell, who some of you all know, previously led up Greater London Strategic Health Authority. She's part of the team and has been there for some of the big announcements. There's something intrinsically human about people, clinicians who have been brought up proper, not wanting, even if they object to everything they're hearing, not wanting to stand up and upset their nan by being rude to a stranger, especially a stranger with a title. So you can use them strategically. Beware benign dictatorship. So there are more than 100 general surgeon consultants in Greater Manchester, and it's fair to say plenty of them have been in opposition to the proposals. That remains the case. Some of them will be in the audience, I don't doubt. I'm not here to tell you that this is not controversial. There's plenty of controversy. There has been over the last 3 years, and it remains. If you want to derail a process, one easy way to do it is to get on the inside of it, and you need to be aware of that potential danger. But you also need to be aware that you're likely to end up with a very small number of people actually drafting the detail. So this is a massive piece of work. The paperwork to it runs to thousands of pages. It's got impact on a 6 billion health budget. It impacts, more importantly, on the healthcare of 3 million people. But the number of people that are actually describing the model of care and how things should be done is very small. You can count them on the fingers of, well, a few fingers, really. And there's an obvious potential danger there. Now, there's roles in public life for a sort of bunker mentality and us against them, and they're all out to get us, and the more they're out to get us, the more it proves we're right. That might work in sport, but it's obviously dangerous if you're into reconfiguring public healthcare. And so I can't really emphasise too much the need to find external advice and the need for external scrutiny of what you're doing, because those of us on the inside are clearly in danger of becoming emboldened by a bunker mentality, and that's dangerous. So bring in external scrutiny. Apart from anything else, you have to be fairly sceptical about people within the system in terms of what they're telling you. So we asked all the trusts to self-assess against those standards. We produced a basket of the standards from what the Royal Colleges had written, and we asked them to self-assess. And in 2012, trusts were fairly relaxed about saying where they didn't meet the standards. There's plenty of amber and red on their returns. They're just self-assessments at the end of the day. But by 2013, they started to think, oh, this is real. And they started to see it as a competition. And suddenly they were sending back returns that were much more green, and yet nothing tangibly had changed. We knew they hadn't appointed any more people. We knew that they hadn't suddenly developed interventional radiology they didn't have the year before. So we brought in NCATs, we brought in external scrutiny, and we asked for evidence. And needless to say, there was a massive gap between what trusts said they were complying with and what they could actually provide evidence for. So be respectful when people tell you they're meeting standards, but actually don't believe anything they say until you've seen hard evidence of it that's been externally scrutinised, because we all have a conflict of interest, and most importantly, that includes me. The NCAT recommendation was to give their unanimous support to the programme, which is helpful, but they also had an insight into variation in outcomes around the city. And interestingly, they said that those trusts with the better outcomes weren't necessarily those that reported higher levels of compliance with standards. It was those that were more engaged with the process, those that were more willing to provide evidence, not only of where they did meet standards, but where they didn't, and those that didn't see that cultural change was such a challenge. I think there's a limited role for management consultants. That might seem a slight surprise because the first reaction seems to be, oh, we've got a project to do, let's send for A, B and C, one of the big 5 management consultants. I've got a healthy scepticism for it. We certainly involve them in Healthy Together, but almost everything they've done we've had to go back and do again, in truth. And that shouldn't be too surprising. We're the subject experts in this arrangement. So it's the clinicians that have to describe what the model of care is going to be. It's also the clinicians that have the intel, if we engage with it, to actually decode all the data out there. And it varies from trust to trust. If you're going to describe that you're going to reconfigure high-risk general surgery, you need to be able to define that, and you need to be able to identify who those patients are in your hospital and in the next hospital. Every hospital's got its idiosyncrasies to its coding department, and you need to work your way through that. We need to describe which cases are going to go to critical care. Management consultants don't do that, and so it goes on. In my experience, by the time you've done all that to the necessary level of detail, all you really do is pass the calculator over to the management consultants and invite them to press the equal sign and take the check. So, healthy scepticism about their role. I said the model needs to be very simple, and on the top line it does. Keep patients local whenever possible so you can integrate with community care, but for high risk and specialist work, do it on a smaller number of sites where you can provide 24/7 consultant care. That's pretty simple. But there are complexities. We're going to have women's and children's hospitals that don't have high-risk general surgery in them. We're going to have frail elderly patients in all our general hospitals, and so on. So you need to be able to provide an offer, a general surgical offer for those patients. That's going to involve the likes of 7-day hot clinics on all sites. It's going to involve ward rounds on all sites to see ward consults. It is going to involve moving some patients, etc. And you need to engage with that complexity. There's corporate complexity. I'd be wrong to ignore that. One bit we've not done so well, and probably should have done, is actually recognise it as a research opportunity. Belatedly, we're seeing the research opportunity of actually studying this at a public health level. I wish we did that earlier. There's probably another Lancet paper we've missed out on. We set off saying there was a case for change based on self-reported failure to meet standards and an NCAT coming in and saying, yeah, you're not meeting the standards, against actually fairly limited self-provided evidence. But I've learnt to trust our judgment on that. So I'm very grateful to Matt Oliver and the Nella team for providing this data. And this is unpublished, and we'll all be seeing this in more detail later in the year. This is 20,000 cases, the first 20,000 cases from Nella from last year. And just 3 pieces of evidence there as it relates to Greater Manchester. So our ability to get consultant surgeons and anaesthetists to laparotomies varies across Greater Manchester from 50% upwards, nearly 2-fold variation. Operative timeliness, there's slightly less variation between Greater Manchester's hospitals, but actually still 1/5 of our patients aren't getting to theatre as quickly as we said they should. And 2-fold variation in our access to critical care direct from surgery, and we know from various studies, Rupert Pearce's work amongst others, that access to critical care is pivotal to good outcomes from major surgery. So actually 2 years after Healthy Together started, our evidence of a case for change is consolidated and grown from where it was when we first set out on it. So I won't read all of that out, but I think you can summarise the first 3 bullet points as: have you got a very clear case for change and model of care that you could explain to your school-aged children? If you haven't, keep working at it, and if you still haven't, drop it. And actually, is the model of care that you're describing something that you'd want for your mum? Because that's the strap line to Healthy Together. And you can't keep this up for 3 years. You can't be in it for the long term unless you're actually wedded to it, unless you actually believe that this is for the best. So you do have to make a personal commitment to it if you're going to have success. You need a due process. You need a professional comms team. You absolutely need to avoid non-clinical compromise. As soon as you start letting the politicians say, yes, but, you're on the back foot and it's downhill in a bad way from there. And then when the going does get tough, and it will, because you'll come across plenty of opposition, you need to take a step back and see what you have achieved as well as where you still have challenges. So we have now agreed 3 specialist hospitals, and we have now agreed 3 hospitals that will stop doing the high-risk work and will be branded for the purposes of general surgery as general hospitals not doing high-risk work. So although there's more still to be agreed, we've achieved a lot. And crucially, no one now questions the standards and no one questions the case for change. Thanks very much.